Well, welcome again to this special episode where we interview some of the greatest minds in the dental field at the Academy of Osseointegration 2024 annual meeting. I'm Wes, the dental guy.
And I'm John, the dental guy. And as we have now concluded the opening symposium of this always awesome meeting, it's been a focus on that we knew that was going to be speaking about what happens with peri-implantitis, peri-mucositis. What can we do about it? We've been challenged already.
We have been placing implants and been around implants for over 20 years. And you and I knew that implants were going to be a part of our career when we both were in dental school and dove into it in that realm. But I never thought that the maintenance of dental implants would be as big a deal as it is today.
Yeah.
We thought implants
thought they're forever.
Forever.
Right?
Implants are forever. Revisions weren't even a conversation we were having. Now we're considering how are we treating the different types of problems around our dental implants. That's been the whole day today, is about understanding why we're having problems, what are the reasons for the problems, and maybe what are some of the treatment regimens that we have.
That's right. And so we're joined here today, this evening, by Dr. Purnima Kumar. Thank you for being with us very much.
Thank you for having me.
Yes. So, well, one of the things that, we today have been kind of faced with, I think, is trying to make sense of a lot of the theories, some of which have been tested, some of which are still theories, but
Sure.
Of what do we need to be thinking about in the world of peri-implant disease? And maybe as we kind of speak with you today, just thinking about your presentation, let's maybe begin before implants are placed. What is it about the environment, the microbiome? You mentioned things about, say, for instance, adjacent teeth, presence of existing disease. How important is that in what we do next with our implant placement?
All right. So yes, great. Thank you for this question. And this is something that I've almost, devoted. So you've been placing implants for 20 years. I've been doing it for 33. So same difference, right? The thing is, when we came into this field, we thought we sold implants to our patients as the caries-free teeth. Right?
That's right.
Right? We said, hey, you get cavities in your teeth, you won't get cavities on an implant. Then things started changing. We said, wait a minute, an implant can get disease as well. And we didn't even know how to measure it, how to diagnose it, how to detect it, much less how to treat it. Today, we've come to a place where we say, listen, the treatment of an implant begins before you place it. Your patient might ask for an implant, but your child asks for a cookie as well, and you say no. And there are some patients who are not candidates for an implant, and you have to bring your patient up to a place where they can be a candidate for an implant. The site has to be a candidate for an implant. And this entire concept is building this philosophy known as primordial prevention. Prevent before you prevent, right? So this is primordial, almost like when the earth was cooling, right? So we're going back to those states. So prevent implant disease before you place the implant. So ideal treatment planning, ideal placement, ideal case selection are all going to be critical, right? And then when you say ideal case selection, you're like, okay, what is an ideal case? What should we be looking for? And that's where a lot of my work is coming in. I'm trying to put the mouth back into the body. And so understanding how different systemic factors, how different parts of your body can impact what's going on in your mouth. If you're a postmenopausal female with periodontitis, what is your, susceptibility to disease? What would be your prognosis versus if you are a 45-year-old male? Right? If you're 500 pounds versus if you're 90 pounds. All of these different factors, let's start building them all into an algorithm that says, this is how this patient needs to be addressed. And this is true P4 medicine, personalized care. And again, bringing back to personalized care, an important part of P4 medicine is participatory. How many times have you bought a car and someone sold it to you without a 5-year, 5,000-mile warranty?
Right.
Do we sell implants to patients saying the next 4 maintenance visits are already paid for? You need to show up and you need to get them done. Do we educate our patients on saying this is how you need to clean your implant?
Yeah, I agree that we have a profession that has forgotten how to diagnose, or maybe they've got comfortable with not treating periodontal disease.
Correct.
For whatever reason. And how, we are doctors, and we have patients that show up, though, that maybe they haven't been diagnosed with periodontal disease, but it's obviously been there for some time. We can see it on the x-ray or through diagnosis through periodontal probing. At what point do you say the patient's ready to have this tooth extracted now that their disease is under control? Speak to that.
I can. I always tell my students, we are dentists. If the dent is out, what kind of an ist are you?
Love it. Okay.
Right?
This is good.
Think about it. We are here to save a tooth, to extend its life for as long as we can possibly keep it in optimal function. And again, without letting, perfection be the enemy of good. Can you keep this tooth in the patient's mouth 5, 7, 10 years more? 3 very important things will happen in that period. The first thing is the patient will learn to manage expectations. Nobody thinks they're going to run the Boston Marathon after a knee replacement, right? Second thing that will happen is that technology will improve. The implant or the treatment that you can give the patient 5 years from today is definitely going to be a newer model of what you're going to be placing in their mouth today.
For sure. That's good.
And that newer model has to live 5 years less in that patient's mouth.
That's right.
Right? So for us, our bounden duty is to extend the life of the tooth by as much as we can. And part of that extension is talking to the patient about what their condition is right now. Right? So patient comes to me, I want an implant. I look at them and say, fine, but I've looked at all of your mouth and you have periodontal disease. And if I put an implant in a mouth that has so much rampant disease and is so inflamed, I'm reducing the lifespan of your implant. We can do this 2 ways. We can treat your periodontitis today and get you to health and then place your implant. Or I can place your implant now, watch it fail, and then come back and place another implant, and whatever is associated with the building the bone back, everything. Because when an implant goes, it takes the bone with it. It just doesn't fall off and leave a beautiful socket for you to place another implant in. It literally trashes the bone as it leaves that place.
That's right.
So, and I'm 0 out of a million times have I heard a patient say, I don't care about my gum disease. I want you to put that implant there.
Well, in order for us to be able to go down that road, we have to understand that we're right when we say that. So talk about the evidence that you presented today about why is it that if we have, say, active periodontal disease on an adjacent tooth and it's, say, a healed ridge site, why would we avoid just placing that implant? It's a nice healed ridge. The bone there appears good, but there may be disease on another tooth. What evidence do we have that creates a problem?
Thank you. That's great. So I stand on the shoulders of giants. There's been so much research before me. But what we specifically found is that at the time of implant placement, when you place that implant and put that cover screw in there, the scenario, the ecosystem that lives in your mouth, that drives the future. The future of the implant is sealed with that cover screw. You literally seal it there at that point, right? So if your adjacent tooth has pathogenic bacteria in it, if your adjacent tooth has inflammation and therefore a lot of cytokines are being released in that area, all of that is carried into that implant site at the time you place it. And then that impacts the bone physiology, that impacts the kind of bacteria that live there, that impacts the resistance to future antibiotics that you might need to use on these people. So the entire profile of that system changes, and you've created literally a pathogenic community that lives there by sealing its fate, by leaving it next to a tooth that's in trouble, right?
Even if we bury the implant, we've still contaminated that cover screw, which then leads to long-term bone contamination. And from what we've heard, that might not show up initially, even at 1 year, 2 years, 3 years, but down the road, this could come back because of that initial contamination.
It's not just a contamination, it's a community that's built, and these communities build these cooperative relationships with each other. So they've set the stage. They're like a subdivision that's already established and built, and they're sitting there, right? They don't have to go rogue until we become susceptible to it, right? It's what happens, right? You may have a gene that's makes you susceptible to a certain type of cancer, but until you expose the environmental variable, you don't get the cancer. People can say, I beat cancer, but you didn't.
I think the people that need to be just excited about this is our dental hygienist. They are key partners in helping the patient grasp the magnitude of what disease process they have, as well as the doctor, of course, but these are the people that are spending time with our patients. How are you educating hygienists in this respect?
Well, our hygienists are always, great partners. They're fantastic partners, but they come in after we have placed the implant. And when you've done something wrong, to push it back to a hygienist and expect them to fix a problem that you, the doctor, with the 2 big letters in front of your name, failed to diagnose and create it, is, I think, very unfair. So, yes, the hygienists are there to maintain the good job that you did, but they're not there to pick up for your failure.
That's true. That's true.
They're not. You're diagnosing.
But they need to understand the prior to implant placement, perhaps, understanding the effect they can have on helping to reestablish
they're seeing the patient with the edentulous spot, and they're saying, hey, this patient could benefit from an implant in the molar location. However, there's some gingivitis we've got to control here. We've got some periodontal disease that we need to control first. They're creating the value for good oral hygiene prior to us doing surgery in private practice.
100%. And that's how it is in my practice as well. But if, something I've learned is if your patient is showing up to a hygienist routine recall, they're already in a good place. They are in a good place. It's that person who walks off the street and tells you, I need a dental implant here. And you say, yes, I'll do it for you. And you say, but you have gum disease. And the patient says, but I want an implant. And then you say, okay, I'll place this implant, but we'll take care of your gum disease somewhere down the line. You kick that can down the road.
Yes.
So that's on you. The patient's already in a hygiene practice. They're doing a fantastic job. They're already talking to the patient. They're pointing out areas of bleeding. They're on top of it. They are usually on top of it. So they're wonderful partners to us already. But my story is usually a cautionary tale for my fellow dental practitioners and fellow specialists. This is where the break in link occurs.
Yeah, every day we see that. And so we get to a point then where we say, okay, assuming that we understand the effect we can have on the future microbiome through what we do, how we can control disease. So we get to a point, let's say that we have an implant that's displaying signs of peri-implant mucositis, and you spoke great length about the opportunities that we have. That you said there were 2 opportunities, I think is what. So talk about that. How is it? What are the opportunities that we have to treat that and maybe potentially change the way that whole system is working to maybe prevent progression?
Great, thank you. So yes, the study we did was super interesting. We brought in patients with peri-implant mucositis. We cleaned them up, brought them back to health. And then we, 3 months later, induced peri-implant mucositis in them by putting a little plastic shield so they don't brush the implant, cleaned them up, waited 3 more months, and did this all over again, right? So now they had 3 hits of disease, and we watched when they came back. After the first hit, they came back. After the second hit, they came back. After the third, they never came back. So their microbiome never returned to baseline. When I mean they didn't come back, their microbiome didn't return to baseline, which tells us that you've already set the stage for a very pathogen virulent community there, right? So how do you change that? So we looked at glycine as a molecule that can help to modulate the microbiome, and we find that yes, it is able to modulate the microbiome. But with that study, I want to make set the stage very clearly. Just ultrasonic treatment, scaling, going in with your ultrasonic, cleaning, what we routinely do, is also effective. Just takes a longer, but it's also effective. The most important part of this is the education that we gave the patient about how they can take care of their implant. So a big part of this entire study was sitting the patient down and doing oral hygiene instructions, showing them how to shoe shine that implant. Because there's no interproximal probe, there's no floss. So giving them that super floss, shoe shining it, how to use an air floss or a Profi Jet or water pick, something there that can actually exert some force. Training patients on being partners in healthcare with us, right? That is important. Also, I want to, at this point, say something, and this might be quite controversial, but I'm going to say it anyway.
Good. Go for it. Please.
All right. We shouldn't be indiscriminately killing all bacteria. So I would not use glycine in patients who are absolutely healthy. To me, I want to be a good gum gardener. When you have a nice lawn in your house, a perfect green velvet lawn, why is it green and velvety? Because you mow it once a week, You don't overwater it, you don't underwater it, you don't over-fertilize it, you don't under-fertilize it.
Okay.
Right?
Yeah, for sure.
What happens when you brush and floss your best twice a day? How much of the plaque do you think you remove? 40%. And that is what is needed to keep your lawn aerated. You need a biofilm. You need a biofilm that thrives on oxygen. What you don't want is that biofilm to become oxygen poor and therefore start fermenting. So what does it take to keep your biofilm, oxygen fed, oxygen rich? Brushing and flossing twice a day.
Yeah.
So if what you're saying here is that you're not recommending airflow around dental implants that show signs of peri-implant health.
Yeah.
We're not using erythritol. We're not using glycine. So on a day-to-day basis, patient X shows up and they show mucosal tissue that is healthy. How are you cleaning that implant abutment? What is your teaching?
Scalars, ultrasonic, whatever we're using for the rest of the teeth, we go ahead and we do the same thing. And we reinforce oral hygiene, make sure that all of this is there. So I don't like to disrupt the microbiome if it's healthy. Because this is something that the immune system has established an equilibrium with. And I don't want your body's immune system to suddenly look and say, wait a minute, there were a whole bunch of friendly bugs here. Where did they all go? And get crazy because of that.
But a counterpoint to that would be that the peri-implant tissue is not as protective as teeth.
That's actually the research does not say that.
Okay, let's hear that.
So when you look at all of the body of research, the peri-implant soft tissue does have the junctional epithelium, that little cuff of tissue that's, holds the tooth tight against the gingiva tight against the thing. The same junctional epithelium is present around the implant as is present around the tooth. There are also fibers right below that, connective tissue fibers, like long ligaments, tendons kind of fibers that are present right below the junctional epithelium there, except with an implant, they're oriented up and down straight instead of running 90 degrees horizontally like this, right? So there is a very strong structure that actually snugs the implant around, that snugs the mucosa around the implant. And when you're in health, when you're maintaining it, when you have plenty of keratinized tissue that actually forms that beautiful cuff, it's fine. It's fine. There is zero relationship between, that says, or an implant. It's only when an implant starts getting inflamed that it gets inflamed much faster than a tooth does. So what it takes a tooth 3 months for gingivitis, it'll take 3 weeks for the implant.
Right.
So when it goes south faster.
Yes.
But it doesn't have to go south.
But we shouldn't be, it sounds like, thinking about, subgingival irrigation with antimicrobials. We shouldn't be thinking about placement of potentially localized antibiotic treatment around these. Is because what we're doing is, again, we're taking out the good guys with the bad, and that does not necessarily result in what we would think it would, because it's taking away the protection of the aerobic bacteria that we want.
Exactly.
And so that's a big, I think, challenge to what many think. I know that many clinicians that we see, maybe something that's progressing, maybe we see some separation or some bleeding, and people jump to, well, let's get some Arrestin in there. Let's get some chlorhexidine in there.
Right.
And I think it's very important for people to understand that's not necessarily beneficial, and the evidence does not support that.
So but the thing is this. You're talking about a biofilm community. And the speaker before me actually showed you with the knee implants and the hip implants.
Yes.
Even the lighting, the fluorescent protein
That's right.
didn't stop shining after a while, right? So it didn't. That's because it went into a biofilm mode of life. You have a biofilm community. You did nothing to break that biofilm. You did nothing to break that thick cell wall that's stuck around it. And you're throwing an antibiotic at it. Where do you think the antibiotic is going to diffuse? Nowhere, right? So yes, if you see pus, if you see bleeding, if you see suppuration from the sulcus, if you see bleeding on probing, your goal is to first mechanically debride the area to remove the antigenic load, because bacterial proteins produce antigens that make your immune system mad, and that madness shows up as either suppuration or as bleeding, right? It's just an angry old immune system. So reduce the antigenic load by mechanically removing that biofilm, disrupting that biofilm mechanically. And then if it still doesn't subside, then you might consider using additional adjunctive treatments. It's not like you clean this tooth, send the patient away 3 months, and then have them come back.
Yeah,
Right.
When you see a problem,
you're going to follow up pretty
you
quickly.
follow up pretty closely.
And how fast it can move, as you said.
Exactly.
So you mentioned there's some interesting research that you're getting ready to publish on erythritol.
Yes.
Can you speak to that?
Well, it's actually in progress right now. So this is the same thing. So every time I show this glycine data, and it's actually going to be coming out in clinical oral implants research next month. But every time I show this glycine data, people are like, oh, I use glycine on all my patients. And I'm like, no, please. I don't want to hear that you're using glycine on every patient who walks in the door.
Right.
Because we don't want wholesale destruction of a biofilm. So to prove that, we started the study where we're actually using erythritol during routine periodontal maintenance.
Okay.
And we have 2 arms, patients who have mucositis, and we're using it on them, and patients who are healthy implants at baseline when you're continuing to use it on them. So it's a 2-arm study, and we're looking to see where does it take us, right?
Make sure that you're right about that idea.
So now it is evidence-based. Yeah. It is a randomized controlled trial, and it's not randomized, but it's a controlled trial, a placebo-controlled, there's a health control there. So we're looking at it as a decent double 2-arm parallel study, and we should have some answers that are backed by data.
That's good.
Yeah, that's what we
really
like to.
Good.
So it's the final, I guess, frontier with this is when we have progression to true peri-implantitis, right? So say we've missed out on our opportunity to change things, or we've struck out more than twice, and we now see true peri-implantitis diagnosis. That changes the whole conversation, does it not?
Oh,
so,
yes.
So speak to that. What is the difference in the way we think about that situation compared to the peri-implant mucositis patient?
All right. So right now, I'll tell you about my practice. Patients walks in with peri-implantitis. I look at it. The first thing I'm looking, what is the pattern of bone loss? Will I be able to regenerate this defect, or is it completely flatlined? Do I have to leave this bit of implant exposed outside? That is where my brain is going, right? The clinician side of me is thinking like that. And then, of course, I look at all of these papers. They're taking a burr and drilling this implant down. And actually, several of my colleagues, Dr. Kotsakis is one, and one of my colleagues from the Ohio State University, Dr. Leblev, she's been studying this, and there's titanium everywhere. And titanium is present, and it can be an inclusion body. It can be a foreign body. So you don't want to be generating that amount of a foreign body that can be an inclusion somewhere else. So then the question becomes, how am I going to treat this patient?
Right.
And so I call it the kitchen sink approach, and it's a technical word. So literally open it up, clean it. I look at it. I'm like, oh, what else can I use to clean here? Can I hit it a little bit of a Profi-Jet and a little bit of this and a little bit of a titanium brush? And, we've been doing that. And then what can I fill it with? Something with a biological mediator and a bone, and cover the membrane. And then, take the superstructure off, put a cover screw, close it all back. This is how I'm working. I'm doing the kitchen sink. But my own research showed that, wait a minute. This kitchen sink is not working for most people, many people, and the recurrence rate is so high because your implant still thinks it has no place to heal, that has no way to heal. The molecular mechanisms that are baked into the DNA of an implant, of any soft tissue, of any tissue that will accelerate a healing process, are lost in this tissue because it's been so long in a chronic non-healing mode. It doesn't know to switch off that mode and turn on the active healing mode, right? So how do you do that? How do you cut? If you have a non-healing ulcer on your hand, what do they say? Freshen the wound margin.
Right.
So we now actually have a study that's founded by the Osteology Foundation, which is looking at exactly this. We have 2 groups, randomizing them. One will get a first stage debridement surgery and followed by a regeneration, and the second one will get a regenerative and this one reconstructive all together in one stage, right? So hold the space. There will be some answers.
Yeah, I think that's the thing is with proven protocols that we've really lacked those. There's been a lot of just like kitchen sink approach, and these consensus meetings where we're merging people from the AO and people from the AAP. And that's exciting because we really do need that in the clinician side. It needs to come away just from, the educational side. I appreciate all the research, but we really need to put all this together so that we can put something in practice.
But I thought what you presented showing the interactions between all of these bacteria and how certain connections, like you say, when there's connections become broken and there's not the communication going on in this sulcus, in this microbiome, that's a big negative. And so how do you hit the reset button is basically what you're asking is, how do we reset this? Does it require, an extensive margin that we have to go back to, or can we reset it using, less invasive techniques? And the idea of all of that data, though, that that you've gathered about all of these bacteria, the interactions, all of these immune mediations that are going on, it's almost big data,
It is big data.
And we have to think, I wonder if the next level with this, as we kind of started the conversation of, can we evaluate the risk factor for that patient?
Correct.
and take that data and come up with a way of saying, you are at a high risk, you are at a low risk, and these are some of the boxes that will be checked that we could create negative problems if this and this and this and this happen. And where do you think we are in that? You mentioned P4 medicine, and coming back to that, how close are we in your mind to a time where we could say, with say salivary testing or something, some mechanism to where we could truly, personalize implant placement and management of these problems, or maybe prevent them?
Right. So yes, P4 medicine is very exciting, right? In the terms of personalizing care. And to personalize care, you really need to understand all the, so this AOAP consensus meeting that we have, and I'm one of the group chairs, so conflict of interest declared right there, is very, very critical in that. For the first time, we're actually looking at exactly that. What are the systemic factors that can contribute to a poor implant outcome? What are the local factors? What are the prosthetic factors? Why aren't we ever talking of implant as a biomechanical failure? Right? Why aren't we ever talking about it? So what are the prosthetic factors? How do all of these come together in this crazy dance, like a ballet pirouette? Like, how does it all come together? So we're looking at all of these factors, and that's what this is setting the stage. And what we're finding is that there are several pockets, gaps where this knowledge is. So the huge gaps in knowledge, we don't have the studies, but at least it tells us, listen, if we need to do a study in the future, this is the gap in knowledge that you need to fill. So we're creating guidelines for clinicians. I hate to say guidelines. We're creating decision trees, decision-making thing for the clinicians, but we're also coming up with a list of gaps in knowledge and a list of where the gray areas are, and bringing them all together to say, listen, you guys, this is how we bring science and clinics together for better patient care and better personalization.
We need groups like this. We need position papers. We need consensus statements. It helps us make decisions. And I really think that P4 medicine is exciting, because it really turns the decision making to something that's maybe quantitative.
Yes.
Which dentists love that.
Yeah,
we are data driven. We're very input driven people, right? And we are evidence. Dentistry is built on evidence. And P4 medicine does something beautiful. It takes 1 million data points, and then it tells you, based on all of those 1 million data points, this is exactly what you need to do for this one patient sitting in your chair for that one site.
Incredible.
Right? Yep. So it's literally like all of those drones come together and coalesce on that one point, and you can do that.
So I want to ask one question that I think a lot of our listeners would probably be thinking about, that it's completely different than what we've been talking about, but it relates. Knowing what we know, knowing what you know and what you've found, when you talk about implant designs, what we start seeing with manufacturers these days, we're starting to see a change in thought process of roughness on implants, for instance. And we have, of course, bone level implants took the world by storm, and we started thinking about, deeper connections and placing implants more deeply subcrestal, and all of these things we're speaking about in terms of, the microbiome and where our microgap is located. All of these things are a huge issue.
Yes.
So as a periodontist, as a researcher, what are you thinking about with implant design, knowing what you know? Do we want to just go back to tissue level? Do we want to think about a deeply placed implant with an amazing connection? Where do you sort of fall in that, in your thought process, knowing what you know?
I'm as confused as you are. The clinician in me wants that perfect implant that everybody looks and says, I don't know which is a tooth, which is the implant. And to that, I want that perfect design that allows me to provide that aesthetically perfect implant. The biologist in me who is looking at, the soft tissue side of things and the biomechanics of that is like, bad idea, super bad idea, super bad idea, right? And then the microbiologists are going even more, this is super crazy. Whoever thought of this, go back to the drawing board. So we haven't reached that happy medium yet. Mm-hmm. And it's fine if your patient's 100% healthy and is willing to, brush and floss 4 times a day and stick. But now we're only looking at cases where those ideal situations are not being met. And how do you match up to those? So yes, there is a happy medium, but again, it comes down to selecting. There is you're never going to run a dental office with one brand of implant, with one set. If you only have a hammer, then everything is going to be a nail for you. You cannot do that. When you go to P4 medicine, it comes at a cost. You have to personalize it. And that comes down to choosing that absolute right implant type, brand,
for that patient,
level for that implant in your patient's mouth. It can be a different one for the tooth on the other side.
These are the things that are messing with us.
Yes, absolutely.
And it's a conundrum that I really feel like is yet to be solved. And I'm excited about what you're doing because it's near and dear to our heart and how we're treating our patients since we've been doing this so long.
Oh, trust me, I take this directly from my lab to my patient the next day. I'm like, listen up. What did I find last night?
Exactly.
So it really is translatable to the patient in my chair.
Well, hopefully you're listening to this and you can take some of these things and apply them to your practice. That's what this is about. That's what the Academy meetings are all about. And I really appreciate people like Dr. Kumar coming on and sharing information from both universities, the Ohio State and Michigan.
Michigan now.
Yeah, Michigan now. And so this has been amazing. So thank you for joining us today. And I really appreciate the Academy for having us here, John. It's been an amazing time so far, going beyond the boundaries. That's what we're trying to do here. We're trying to look at the things that we've done before, the hard stops that we've had to make, but looking beyond that. Don't look at that boundary as like, this is not the end game. 2024 is about what's in the future. And so I'm excited about treating peri-implantitis. I hope we don't see it next week.
That's right.
So for Dr. Kumar, John, myself, Wes, we are the Dental Guys.